And the first presentation, these are all going to be in pediatric lupus. The first presentation is entitled Provisions of Quality-Driven Care in Childhood-Onset Systemic Lupus. The presenter will be Dr. Brunner. This is a multi-center international study with centers in the United States, Slovenia, Argentina, Hong Kong, and the United Kingdom, and Dr. Brunner will be presenting.
Well, thank you very much for providing me with the opportunity to present the results of an international project on the provision of quality-driven care in childhood-onset SLE. Quality indicators are measures of quality of medical care, and for your convenience, I provided the definition of the Institute of Medicine of the USA below. Quality indicators are based on the available scientific evidence or medical expertise, and adherence to quality indicators is thought to improve the prognosis of patients over time. As you may know, there are quality indicators for adults with lupus, and they have been published actually 2 different sets by the ACR and EULA. However, these quality indicators are not necessarily applicable to childhood-onset lupus, and this is because of differences in concerns about growth and development, differences in the setting how medical care is provided, and also differences in disease severity. Based on this lack of quality indicators, we started a project where we aimed to achieve an international consensus around a set of quality indicators for the provision of medical cares to children and adolescents with lupus. Formal consensus methodology was used to achieve an international agreement among pediatric rheumatologists organized in CARA, PRESS, that's the European group, PRINTO, and PANLA. 2 Delphi questionnaires were performed, considering the current scientific evidence and also survey respondents' feedback. The consensus level was set at 80%, which is quite commonly done. As to our results, we had a very high survey response rate between 76 and 87% to both of our surveys. There was broad participation around the globe. And the median years of medical experience in treating children with lupus among the survey respondents was 16 years. In the following, I will show you the 26 quality indicators for which consensus was achieved. For your convenience, I indicate those quality indicators that are identical to those in adults with lupus with green. Consensus was achieved about a set of lab measures that should be tested in patients in whom you suspect new-onset SLE in children, and also in whom you have newly diagnosed lupus. Imagine the setting that you get a patient referred, you're pretty certain about the diagnosis, and that would be the core set of lab measures you would order. There were also quality indicators achieved for the general prevention of disease flares. Specifically, there were quality indicators around the vaccination of patients with lupus, in that vaccination should be provided for influenza and encapsulated organism. There was also consensus that education about sun avoidance should be provided, and that quality indicator, written in an if-then statement as commonly done, is identical to that used for adults. There was also agreement that a good transition plan needed to be developed before a child is transferred to adult care. 7 quality indicators around the topic of nephritis and hypertension were developed. If a patient with lupus was newly diagnosed with lupus nephritis, then, as recommended for adults, a renal biopsy should be obtained, a urinary sediment analysis done, as well as measures of proteinuria and renal function obtained. Like in adults, proliferative lupus nephritis should be treated within 1 month with corticosteroids plus an immunosuppressant. And patients without known lupus nephritis, if they newly develop significant proteinuria, defined at more than 500 milligrams per day, or have a significant worsening of the GFR, they should also receive a kidney biopsy, and that's a quality indicator that's different between adults and children with lupus. Furthermore, if a child with lupus who has known lupus nephritis is seen in your clinic, then follow-up should occur in at least 3 monthly intervals, and close follow-up is also recommended after a renal flare has occurred. Furthermore, a child with lupus nephritis with ongoing proteinuria of at least 500 milligrams per day should receive treatment with an ACE or an ARB unless there are contraindications. Furthermore, if lupus nephritis is complex, co-therapy with a nephrologist should be considered. In terms of medication management, many of the quality indicators for children are similar or identical to those for adults. Again, like recommended for adults, whenever new medication is prescribed to a child with lupus, then the benefits and risks should be explained and documented in details. Also, and that's different from adults with lupus, every child with lupus is recommended to receive plaquenil therapy or antimalarial therapy unless there are contraindications. Also, children with lupus who are on a higher dose of steroids that doesn't seem to be acceptable for chronic use, in them, effort should be made to taper medication, and if tapering is not successful, then an immunosuppressive medication, a steroid-sparing medication, should be introduced or its dose increased. In terms of medication surveillance, pediatric rheumatologists agreed on certain baseline lab tests that should be done when treating patients with oral steroids, NSAIDs or hydroxychloroquine, azathioprine, IV cytoxan, oral cytoxan, sulfate of cyclosporin, and certain sets of lab tests are recommended at a minimum to be performed for patient safety. In terms of bone, eye, and risk counseling, all these indicators are different from those with adults with lupus. The pediatric community agreed that if a patient with lupus receives chronic steroids, then bone mineral density should be documented in the medical record, and if this measurement was lower than -2 C-score, then bone mineral density should be reassessed or remeasured within 1 year. Furthermore, if a child is on steroid therapy chronically, meaning for more than 3 months, then calcium and vitamin D medication supplementation should be given. Last but not least, if a child with lupus is treated with steroids and or hydroxychloroquine or an antimalarial, then eye screening should be done at least annually, and that's different from the recommendation of the American Academy for Ophthalmology. And if a child with lupus is in your clinic, then regular education should occur about cardiovascular risk factor. Given the age of the patient, those discussions should be done with the parents and also in patients older than 13 years in 1 to 2 yearly intervals. In terms of lifestyle modification, pregnancy, and MPSLE, all these recommendations are identical to those for adults with lupus. Again, children with lupus should be educated about lifestyle modification that may be beneficial to them, including smoking cessation, weight control, and exercise. Furthermore, we don't like to see that, but it does happen in pediatric rheumatology clinics. If a child with lupus or adolescent becomes pregnant, then anti-SSA, anti-SSB, and antiphospholipid antibody results should be documented in the medical record. And furthermore, if a child with lupus is found to have major neuropsychiatric manifestations, then immunosuppressive therapy should be considered. In conclusion, an international consensus around quality indicators for children with lupus has been achieved. 11 of the 26 quality indicators for children with lupus are identical to those for adults. However, often stricter than adult quality indicators are recommended for children. An example may be screening for osteoporosis, osteoporosis prophylaxis, vaccination, and hydroxychloroquine use. We hope that these quality indicators will help define the minimal standards of medical care for children with lupus. At the current time, benchmarking efforts are ongoing to delineate the current standard of medical care for children with lupus around the globe. And this is anticipated to help guide further research in children with lupus and with research allocation for grants. This brings me to the end of my presentation, where I would like to acknowledge the funding agency and all the pediatric rheumatology around the world who participated in this study, and they are written here in very small font, so if you sit in front, you may see them. Thank you for your attention.
Thank you. This paper is open to comments, questions. Please use the microphone.
Hello? Hello? Hi, David Eisenberg, London. Thank you for that. Very interesting. 2 questions. Did I read it right that you were not recommending antiphospholipid antibodies for the children with lupus? That seemed odd if I read that right. And secondly, I wondered if you would like to comment further about the use of the annual eye test, which certainly, as you said, in adults has been pretty much forgotten about now. 10 years ago, the British Society of Rheumatology and Ophthalmology agreed that the pickup rate for anything bad was so incredibly low that they just stopped recommending it.
Okay. So the recommendations that have been made are based on consensus. And it was felt that for patient safety, screening should occur in at least annual intervals. Almost all children with lupus are treated for a considerable amount of time with steroids and also with hydroxychloroquine. And for both medication, screening for ophthalmologic abnormalities needs to be done. I know I'm aware of the recommendation that came out of the UK that during the initial 5 years, testing may not be warranted, but that was the consensus among the pediatric rheumatologists. As I said, benchmarking needs to be done, and further scientific evidence is for sure needed among children with lupus to find out what is the most appropriate screening interval. As to your first question, I'm not exactly sure whether I understood it. It was something about antiphospholipids. Could you repeat your question, please?
Yeah, on the slide, you had the list of tests which were recommended. If I read it right, there was a bar across the antiphospholipid antibodies for the children.
There were 2 sets of labs. One's for patients who are sent to you with a suspicion of lupus. It was felt with a very, there was no consensus achieved that antiphospholipid antibody testing should be done in those. I think one of the reasons was a cost consideration. At least in some countries, the testing for lupus anticoagulant and phospholipids is quite expensive, and it was felt that this testing should not be part of the core testing set. As I said, these quality indicators are minimum standards. If in a certain situation you need more testing because you have a clinical suspicion, then by all means you should do that testing. However, as a minimal standard, it was not recommended.
Thank you.
I realize there are other questions, but I think in fairness to the other speakers, we'll have to move on to the next presentation. Thank you very much, Dr. Brunner.